limited days in each direction, which precludes any option for an urgent return back to Earth, leaving the crew truly self-reliant. In case of an emergency, immediate evacuation from Moon, what we are talking of scoop and fly is evacuation from there, or stay and play means manage the situation over there. May not be possible either. In the best case scenario, the delay between decision to evacuate and reaching the medical facility on Earth would be more than 4 days. Sorry. A rescue aeromedical operation coming from Earth would not impact the initial management of casualties, since it would realistically take several weeks for a team to arrive on site. I mean, to send somebody from the Earth, a medical person who is trained from here to the place, either Moon or Mars. So this we can take some time to see this. So this is what actually the medical supplies that will go along with the space kits. In the early space programs, those are simple diagnostic tools like maybe we can take them as a monitor, clinical monitor to see the heart rate, blood pressure, respiratory rate, and temperature, which is actually monitored by the physicians on the ground. Medications, they used to take a few oral and IM medication. This is still 1980s. Surgical tools, none. Organ support, none. And support facilities are also none. And hardware information technology or the standard audio communication, which used to be there. So now what we are placed, where we are placed. Current International Space Station medical kit contains a proper monitor with an electrocardiogram, an ultrasound machine, point of care, limited laboratory tests also can be done in the space by the astronauts. And medications, extended list of oral medications, some IV, including IV morphine and ketamine, and surgical tools. You can even perform a minor surgery in the space. So organ support, they have now automated external defibrillator and a simple ventilator. And support facilities, we have now a foldable stretcher, IV fluids 4 to 5 liters, and oxygen and nitrogen tank. And also the coming to the IT, we have real-time telemedical link with audio and video now. What is the proposed space exploration kit for the Moon and the Mars? Because we are thinking of colonizing the Mars, and also more and more man travels to Moon and Mars. So going forward, it's to be just like what Sharda told in the last class, artificial intelligence is taking over. So artificial intelligence, embedded ultrasound, extensive laboratory tests, including microbiology, and medications or extended oral and IV medications, including antibiotics, sedatives, vasopressors, and inotropes. And a surgical kit would be advanced surgical kit, including endoscopic surgery, 3-dimensional printing of tools and implants. You just see the scope of this. They are actually planning to do it on the outer space. Organ support, we have video laryngoscope, advanced ventilators, syringe drivers, hyperbaric chamber. And support facilities would be medical bay or module, on-site IV fluid generation, and oxygen concentrator. And hardware and information technology would be artificial intelligence-based decision support tools. So this is how they want to go ahead in the future, in the mid 2020s, which is just a couple of years away from now. So this is the proposed space exploration kit they're planning now for the missions over there. So coming to the onboard medical skills, what is required? The current International Space Station program requires the onboard presence of a crew medical officer, which is an ideal scenario, who is not necessarily a physician. So the best physician profile for a space exploration mission would be an emergency medical doctor. So the ER guys can happily apply for NASA, with additional training in surgery and wilderness medicine. So importantly, the crew physician will spend most of the time on the non-medical tasks, which is obvious because he has some medical knowledge. So he has to prepare for the gravity and also how to live in the space, in which they must be proficient. The crew doctor will need to have a broad knowledge base and to be competent in basic surgical skills and in the management of critically ill and injured. Most likely, a single crew physician will oversee all aspects of patient care, possibly endorsing several roles such as being both the surgeon and the anesthesiologist. So what happens if he becomes incapacitated? So the skills redundancy will be critical. You have sent a physician and he becomes injured. To enhance crew safety, particularly if the designated crew physician becomes incapacitated or dies. In this situation, it has been suggested that non-physicians could perform advanced medical care. So it therefore appears advisable to train several crew members, not only physician, to manage the most common emergencies. For example, matching the first level of competency of WHO medical competency models, which corresponds to basic resuscitative and primary trauma care that do not require extensive equipment or skills. Coming to the telemedicine. So near real-time communications are possible between the moon and Earth with delays around 2 seconds in each direction. So the latency will allow voice and video communication, but most likely not remote operation of hazardous equipment like a surgical robot. However, in the case of Mars, delays in communication of 4 to 20 minutes in each direction will preclude real-time communication.
స్లోగా చెప్పు శ్రీకాంత్, పర్వాలేదు, కొంచెం స్లోగా చెప్పు, నో ప్రాబ్లం.
Okay, sir. Thank you.
మంచిది.
Yeah, thanks. However, in the case of Mars, delays in communication of 4 to 20 minutes in each direction will preclude real-time communication and remote control of equipment, which is the very reason they are actually planning to upgrade the medical equipment and do the training part more. Because in Moon, a real-time communication can be actually set up with just 2 seconds in delay. So unless they are planning with a surgical robot and all, they are absolutely fine for managing basic emergencies. However, in case of Mars, the delay is more. So guiding from here and they doing there is actually out of possibility, which is why they are planning to do the training part more and upgrade the medical facilities what they are taking from here. So this leaves the option to use asynchronous remote support, which was demonstrated, for example, a simulated appendectomy on Mars. So what they are doing now, so they're actually training the people with a simulated scenarios. So like simulated scenario on Mars, simulated scenario on Moon, based on the gravity and all, how they will operate there if something comes, simulated appendectomy or simulated some other fracture femur. How in Mars they are being given training on the Earth to perform a procedure if at all something happens over there. So the best case scenario for this telemedicine is how this all this knowledge is helping is, so recently just like 2 years back there has been an incident, this I shared with our orthopedician Dr. P.V. Ramesh too. In Antarctica, while they are on some mission, the NASA guys, actually one fellow had a fracture patella, and from Boston, anesthesiologist and orthopedic surgeon guided through the communication links, video and audio links, and actually their non-medical fellows, they have given spinal anesthesia and performed tension band wearing of patella. They're both non-medical and they have done under direct video communication from here, just like 3 Idiots movie, how American conducts delivery, the same thing. So this is the best example they have given that how this actually knowledge is helping in remote situations and all. So coming to anesthetic consideration, physiological considerations, there will be obviously gravity will not be there. So these are all anticipated fluid shift towards the head, reduction in blood volume, cardiac function, and also volume. Increase in lower extremity venous compliance, there will be venous stasis. So alteration of the arterial systemic resistance and baroreflex response. This is how the fluid shifts will be there. As we can see, we will see in microgravity means in the Mars and all. situation where facial puffiness is more, the fluid shift will be more towards the head. And also post-flight, this is another situation where they have talked about in this, immediately coming after space flight. After they landed in Earth, also they will take some time to get their hemodynamics to baseline, and also all these fluid shifts, and also all these will take some time to get back to normal. There will be overcorrections and undercorrections and all. So we have to take into consideration all these, even not for a surgery on Mars, but even after returning to Earth, they will take some time to get the physiology back. So there will be, as said in the earlier slides, increased risk of sepsis in the outer space. So the reasons being confinement, restricted hygiene, altered immune system, decreased antibiotic activity, and potentially increasing bacterial resistance. Newly identified dynamic changes in the microbiome of the subjects and the environment. These are all the causes where there will be increased risk of sepsis, particularly in this group of population. So coming to the choice of anesthetic techniques. So to this day, no anesthetic procedure was ever required during or shortly after a space flight. For space exploration missions, in the absence of strong evidence, it appears sensible to formulate choices based on a worst case scenario approach. So astronauts requiring surgery should therefore be considered be severely deconditioned, hypovolemic, difficult to intubate, and intolerant to succinyl choline. Have a full stomach and be managed by non-medical person with limited training. So even most of these will apply to immediately after returning from the space flight. So overall, we argue that regional anesthesia should be attempted whenever possible. A combination of a short training before the mission with the on-spot refresher should give crew members a good chance of succeeding at the regional block. When not suitable or in case of failure, general anesthetic will be necessary, just like how we do here also. We recommend the implementation of a limited number of simplified intravenous anesthesia protocols. Concentration for procedural anesthesia, peripheral surgery, or superficial trunk surgery. General anesthetic with endotracheal intubation for head, face, and deep trunk surgeries. Using volatile anesthetic agents would generally be ill-advised in such small enclosed environment. So coming to the surgical factors, conservative whenever possible. So here again, the major surgery or like what they anticipate the most common is some limb fracture due to some accidents in the space. So actually, their advice is to manage with some slab or casting to avoid surgery in the space. But again, the problem with that is they will actually end up being shortcoming in their escape from the mask, because it's a cramped up space, and this fellow will not have proper leg space to him to rest and all. So the surgery they have advised is intramedullary nailing of the femur. And again, the challenge comes of use of the equipment and all. So the X-ray machines, portable X-ray machines only, they will the carrier of portable X-ray machines and all is very difficult over there. So the modality of choice they use for reaming and all is ultrasound machine. So using the ultrasound machine, they will carry out the intramedullary nailing of the femur. And also again, with ultrasound, the distal locking screws and all, it will be difficult to accurately do the distal locking with the ultrasound. These are all the problems they have, and the training is ever going on to make it more and more easier for the crew people to manage these sort of situations. And again, if the IM nailing is carried out, the problem will be again healing challenges will be there. So with the lower gravity, the bone healing will take definitely much longer time, or most of the cases they'll land up in non-union. So these are all the challenges pertaining to the surgeries and all. But day by day or every year they're trying to get in new technology and actually help the people out there to perform surgery. some things like in the few coming slide, we will see like what are all the modern equipment they're having there. So the other big factor being behavioral health and performance. This is a big thing when coming to space, and taking the critical decisions out there will be very difficult based on human factors and non-technical skills. And also collective cognition. This particular term, collective cognition, is very difficult out there. Uh, because normally also they stay away from home. There will be a lot of psychological issues, and decision making will be very difficult, and especially when something like this medical emergency comes, the staying tight and taking the decision is very difficult out there. They spend a lot of time in the training about psychological conditioning of. So actually, the crux of this topic, from space to Earth, the translation of a space technologies to enhance the terrestrial anesthesia. Many technologies and concepts developed initially in the space sector have benefited terrestrial medicine, anesthesiology in particular. To begin with, space agencies are known for their vast emphasis on the risk assessment and culture of safety. The National Aeronautics and Space Administration, which is NASA, was the first to propose the concept of safety matrix, which quantifies the impact of potential threats by combining their likelihood and severity. Related approaches of risk quantification stemming from the aerospace industry have been applied to healthcare and, in particular, anesthesiology. So these are all the things which have been initially introduced by NASA and we are using now. So to telemedicine technology and biotelemetry, robotic ultrasound machines, artificial intelligence embedded ultrasound machines, these are all we are going to see in our day-to-day practices in the future. So remote controlled robotic laryngoscope, do you even imagine that somebody is controlling from here and they can actually maneuver the laryngoscope in the outer space, or at least in the low Earth orbit for now, to accurately guide the fellow to put on the tube. So closed loop systems, we know these for the delivery of IV machines. All these actually are being developed by NASA initially, and they are being exploited to the test. Telemedicine we are using now. Closed loop systems there have been in use. So in the future, coming future, by the end of the decade, maybe we will see these robotic ultrasound machines, AI embedded ultrasound machines, remote controlled robotic laryngoscopes too, where we will be practicing in some remote area and somebody can guide us in a difficult airway scenario. So to conclude, as the ambitions of the human space travel expand, the risk to health and probability of severe medical events intensify. While exemplary planning can go as far as to mitigate risk with provision of necessary skills and equipment, the heterogeneity of medical and surgical emergencies demand considerations of in-mission uncertainties, personal training, and on-site synthesis of equipment. The medical community will no doubt play an essential role in planning future space exploration. Provision of acute care remains a key barrier, although one that through improved understanding and technology can potentially be overcome. Finally, the lessons learned and materials and protocols developed in that process are likely to benefit physicians and patients on Earth in resource-limited, isolated, and austere environments, but also potentially at scale in very conventional hospital settings too in the future. So this is the clinical focus review, which is published in anesthesiology by ASA last year. And thank you so much for listening to this topic. This is how they actually carry out the simulated intubations and surgeries on Earth.
Yeah, excellent topic, Dr. Srikanth. Very interesting. And you mentioned some surgery was done in Antarctica patella fixation. So these people should have, those who are going, should have minimum basic skills, because a person who is a paramedic or who is non-medic, he cannot give a spinal anesthesia. Even if you are guiding him also, it is difficult to give. And fixation also, if we ourselves cannot fix a patella even with the guidance also, it is very difficult. I think those who are going there, the most basic things has to be identified and has to be trained. I think the module sort of thing. I think NASA might be doing that.
That training part they have emphasized on very training of basic surgical skills and anesthetic skills there.
Not
Actually,
only that, various other things also regarding medical, because there it will not go. More people will not go. No, only few people go. They need to be at least not masters in all, but at least they need to know the basics. Most of the things.
They should be like multi-talented like you.
నాకెందుకు సార్ మళ్ళీ
అలా కాదు. Just like-
కుకింగ్ తెలవాలి, అన్ని తెలవాలి కదా వాళ్ళకి. సో
No.
బేసిక్ ఐ డోంట్ నో, కుకింగ్ కూడా రావాలి కదా వాళ్ళకి.
ఆల్ కింగ్స్ రావాలి. కానీ ఇంకోటి ఏంటంటే అంటే సారీ శ్రీకాంత్, కెన్ ఐ జస్ట్ సే?
yes, sir.
Yeah. So because there are a lot of, I think a few points which you emphasize is, one is the telemedicine. Second is the simulation. Resource limited setting work. Fourth is the training part of the non-skilled people to the training level of excellency. And fifth is the how the people will take a decision in the stress levels. Like a COVID time, you get a COVID, still you will work. And that how do you really take a decision? How do you work in the stress levels and different environments? These are all the points stressed here. And as you told rightly, because this NASA and this aerospace, everything is going to extrapolate our own this one, and in our day-to-day work, and definitely these are all going to be very useful, because we don't know what are the testings they are doing for a stress. Like before they take off, they train, they test, they do everything. So like anesthesia has been developed, what I understood as per my remembrance is from the aeronautics, because there are 138 checklists. Accordingly, like the checklist has been made for anesthesia to prevent complications. And most importantly, future is going to be, I believe, simulation-based training is going to be one of the key aspect, and along with the Zoom and telemedicine because of the COVID. Another point I would like to say is that it's not in context of this class. The COVID scenario, children who have been born, their psychological is going to be different after 20 years. It's going to affect the society after 20 years. And the stress levels are going to be different for them. And I've seen few people, the milestones of the children. Yesterday, I was discussing with one of some bureaucrats. So they were telling the delay of 6 months of milestones for entire the children, it seems. So these are the 5-6 points what I thought from this class. Again, I would like to repeat, one is the telemedicine importance, and second is the stress level, how you take a decision. Third is the training of the unskilled and or the people who are coming to the skill, like Jekina Boyna is telling that multi-talented persons doing the get other things. And simulation-based training of the people to prevent the complications, make a scenario, like a worst case scenario, what we can do, all these things. So these are all really, really valued and important points. Really, thank you very much, Srikanth. I leave this my instead of more than time. Thank you very much.
Thank you, sir.
Madam, Rani Madam, మీకు ఈ క్లాస్లు ఉన్నాయి యూకేలో?
Sir, with this your extrapolation,
చెప్పు చెక్కినా, because this is useful for your college training.
extrapolation, which as you mentioned, I think the most important is here the basic level of training is very, very important, sir. As we are in the corporate sector, we may not understand that the levels of knowledge will be such a low in a medical college or some of the nursing homes. So, and most of the times we are working in the city. So I think we need to, as a Morton group, we need to develop some set of skills for specifically for nurses, and even the most of the
modules.
Hello?
Modules.
Yes, sir. We need to develop certain modules for nurses and basic things. Even we may think that these basic things everybody knows, but they doesn't know. I think we need to develop that, sir, sort of skills. And if possible, we can go with Shrikant and everybody with the use of technology. We can do ventilator workshops or what we used to do with our own simulator. I think that we should think very strongly into that, sir. Mohan, sir.
I'm for it all the time. I'm for it.
Yes,
Srikanth, very good resource person for us.
yes, sir. Because see, no need. Suppose this is Sangareddy is here. Sangareddy, no need to come to Sangareddy with that mannequin and show everything. In the Vizag, we can ask them to adjust the settings. One person will adjust and how the flow is there and everything we can show them, and we can do a workshop, both theoretically and even practically. We needed strong technology support.
I am actually telling this to Rani Madam since 2 years to make a 10 case scenarios, anesthesia side 10 and critical care sides and 10 and emergency medicine 10. So 30 case scenarios to be made proper this one. Maybe now the team of you and Srikanth they can do. Is Rani Madam in the team, in the group, joined? Anyway, our Anuradha is there. Anuradha can do that. Because if you give some work, academic or administrative work, she performs very well. She has done excellent works of 2D course. She has done excellent work of FCACS courses, all these things. Anuradha?
Good morning, sir.
ఇది కొంచెం టేకప్ చేయమ్మా. జక్కిన చెప్పింది చాలా పనికి వస్తుంది ఫ్యూచర్కి.
Yes. Yes, sir.
రియల్లీ గుడ్ క్లాస్ శ్రీకాంత్. సస్పెక్టింగ్ ఎలా ఉంటుందో ఏంటో అనుకున్నాను, బట్ రియల్లీ నైస్ టాపిక్స్, నైస్ పాయింట్స్. Now Jekna is understanding how difficult it is in the society, how the people are very innocent.
Wait, this is only subject wise, sir, innocence.
Any questions, anything? Like one thing I didn't understand, Srikanth, you told that why the fractures will occur when they go to space, because normally movement is slow. That was not understanding. In its terrestrial area, it's fine, slippery, all these things. But in a space, why the fractures will occur?
They say that while they're moving out, sir, on manned machines and all, sometimes there will be high pressure scenarios, it seems, sir. But very unlikely, but it can happen according to them.
Because
so
as per
that scenario actually didn't happen, sir. So that's just a starting lines for the as a like prologue to the review and all. So they are anticipating everything like that. Till date, no procedure has been done on the space or even after immediately returning. That's what they wrote in surgical scenario. But they're preparing for everything. That's what.
You told regarding patella fracture.
Patella, that happened, sir. That's actually in Antarctica, sir, not in space. That's how they're telling how this knowledge is actually helping in Earth. To that example they gave. In Antarctica, when there are no medical person and all, the crew which went was trained crew. So from the Boston, these guys are guiding them, and they have performed the surgery over there. Training is the key, sir. Proper training and psychological conditioning and all these are very much important. Then, as I said, now in COVID scenario, we can apply to that decision making.
Yeah, I want to give you one work, Srikanth.
Sir.
As you're doing good topics, I want to ask you ECMO CPR.
ECMO asal knowledge less.
It's not for ECMO. There's no knowledge required for ECMO. Just how early, how to. I want the mechanical action of. Normally, I want to take up to this into the city that Any CPR to be done not with the human, like a chest compression should be stopped. Only the machine should be used. There is a compression machine, no? Should be used.
Compression machines are actually.
And it doesn't come once the rhythm does not come. Immediately put onto the hand ECMO, just like hand rolling ECMO, and look for a 5H5T, then assess. And the reason for this doing is one, to save other organs, and so that organ donation can increase. Two, if the by lucky chance brain comes back, it is good. Particularly, it is useful more into the acute conditions and cardiac conditions. Other conditions, it's not useful. It is mainly useful for the organs only. So we really want to promote that and use of it. That's a real interest what I have. So for that, I just want you to consider one class.
Study, sir.
Sir, as you mentioned, Mohan sir, that anesthesia cases has to be there, sir, included into this program, because I see in even remote of the places, qualified anesthesiologists are there, and they are doing a good job. And this should not, our training of anesthesia case scenarios should not go into the wrong people hands. So, what is your opinion on this, sir?
What is the wrong people hands means?
Means MBBS doctors start managing anesthesia.
The problem is whatever you do, my concept is little different. I agree with whoever is going to tell me or convince me. The problem is qualified people are not going to the peripheries. And qualified people have an ego of learning. Second, third person, like for example, Anuradha is an anesthesiologist. She has learned TE, she has learned cardiac anesthesia. But if other anesthesiologist comes, if the age is more than her, she's my junior. And she does not know much because communication skills. Or she tells something, I'm just taking example of Anuradha, not because I know her, I'm very close to her, she doesn't feel bad. That's why I'm telling, please consider this. So, and when somebody says, this fellow also anesthesia, I'm also anesthesia, what is there to learn from him? These three things are going to be there of many mindsets. There is no receiving and acceptance level. Once you start training more and more people of MBBS, other people, not for giving anesthesia. See, anything what you do should be to prevent complication in the society, to do the first aid. These are the only two things we can do. We cannot really treat anybody. What are we going to do? You need to give safe hands. You need to give primary, like for example, RMPs are there. They are going to treat the patients. Most of the people in India, at least 40% of the people in India get treated by RMPs. RMPs live by referring them to us. Not that there are a lot of physicians who will not go to them, because the patients will go to the RMP because one, he is accessible, is available, and is affordable. These are three things in the health: affordability, accessibility, availability. That fellow is available 24/7 near the house. He calls, he comes home, he gives the injection, and he takes only 10 rupees or 20 rupees. What he gets maybe another 100 rupees from the medicine, but they don't bother. And because of that, what complication is going to happen? How many lakhs he is going to spend in corporate hospital? Patient does not know. So if you really want to help the society, it is not that you should train and teach only anesthesiologists. You train maximum number of people who reach the people. Like for example, you look at the national programs of IAS or deliveries. There's something called IAS. The money gives to the IAS, which they reach to the each area. So that is why the knowledge sharing should not be limited to some people. It should be given to the maximum people. There are certain people who won't get a PG seats because of their caste or religion, whatever you call it as. And the people who doesn't have a knowledge also can become qualified. And also at the same time, who are very interested, like MBBS guys, they do very well work. Some people cannot. So you cannot limit only to anesthesiologists. You start telling everybody, it's not unethical, because intubation, CPR, central lines, this is the basic requirement for any MBBS doctors also. So that is the reason there should not be any limit. These are my concept, my thinking. I may be wrong. If you people are able to tell me something else, I am ready to listen, accept, and change myself. Thank you.
Hello, sir.
Chappan, madam.
Morning, sir. Sir,
Morning.
you said about UK simulations and all. There they have simulation training for nurses, simulation training for paramedics, simulation training for doctors. In doctors, they can be like just graduated doctors. Simulation trainings are there, as you said, like any emergency, any doctor, like ER doctors, post-MBBS doctors, they all do emergencies. Some particularly related to anesthesiologists, they have anesthesiologist simulation training. So like that, they divide to different types of simulations. So even paramedics and nurses, they all know how to deal with arrest scenario, anaphylaxis scenario, sudden collapse or intubations, all that they also know. Cannulations and all those things, they have the simulation scenarios and proper like syringes, pre-filled syringes, like color-coded syringes, and they do that actual scenario with the team. They do that and they see the changes on the screen. So it's like as Srikanth said, even non-medical people, they did that. So probably with this kind of simulations, anybody can learn. It's like that. So, but we are doing only doctors and specialty doctor simulations only. But there are so many kinds of simulations. So if it reaches to that stage, probably paramedics can do that and nurses can do that. So everybody can do more or less what we do.
As Animal is telling one thing I would like to say, in foreign countries, the simulation courses are very, very costly and really, really costly. Even when I trained for Edikanal going for this, I mean, for us, for Indians, it's going to be too costly. So better to get trained in India. And if you tell about India, I do not know any other center. The best center, what I know, is a GSL Medical College. Anesthesials, every PG should go to Rajahmundry GSL College. And there is a gas man who's been connected directly to the gases and gives the gas monitoring as well. And that's real case scenario benefit, which can be recorded and kept and shown to somebody. Maybe that can be taken up by Anuradha, as I was talking about, and going there, recording it and making a scenario. I've been telling you for last 2 years, Dr. Rani, also about ER and critical care scenarios. That's going to be the excellent module for PGs or MBBS doctors who are working in anesthesia and emergency department and critical care. And coming to this part of training purpose, madam, definitely the simulation is going to be the future. And you have a hands, IV cannulas, everything. Every training of this one is going to be, as Jekina is telling, as a modules, definitely I'm very much supportive. It doesn't matter from the group or personal. Even there are only 5 points to remember. One, any video should be less than 3 minutes because people will not watch more than that. And it should be gist and should have a written material down clearly explaining it. And it should be professional fellow recording, not you and me, and proper editing and the promotional activity by somebody, a very famous figure. These are things required, which we can do, Jekina. And I'm interested if somebody is supportive to me with the only time and their mind. Thank you.
Can I add one point, Srikanth? According to our topic. Actually, these people are more prone to pathological fractures because of weightlessness. No, that's why after a few months, patients are gone to osteoporotic changes. That's why more prone to pathological fractures, more in femur, and decompressive sickness also is there. So that's why oxygen cylinders are also keeping in space also. So that's why these people are more learning in regional blocks. So before training only, regional blocks is well versed. After that only, these people are going to space.
And one more thing, Anuradha, I want to know, in the space, the CSF will come and the drug will enter into the CSF. How will it work? Because in the gravity, in the normal temperature, in here, normally it goes. So there, how it is going to really work in the space, I don't know, I'm just asking. Shrikant.
So no idea. So maybe isobaric can do, not hyperbaric group can and all. Yes, sir. It's the gravity will be lesser definitely, but no idea seriously. Madam?
Spinal not mentioned, sir. Only regional blocks like this is mentioned.
So there might be a chance of a total spinal also because of the loss of gravity and less gravity. The drug dosage should also be monitored, and the spread is also not much reliable. As of now, TY is the only thing that can be given in out of in deep space anesthesia or out of earth anesthesia. But this regional blocks to some extent, but neuraxial blockade and total general anesthesia may not be as good as general anesthesia involving volatile gases may not be the ideal thing as of now. Maybe in future we might have better data how the volatile anesthetics and spinal anesthesia will affect in deep space.
Volatile anesthetics they are not recommending.
I think Baker, what he told is looks more logical and practical because of total anesthesia as well as TIVA and as well as in different areas. And I think, am I right, Shrikant?
Yes, sir. The telemedicine also, the communication gap maybe, I think 2 minutes, Shrikant. I think 2 minutes.
For moon, it's very less, madam. Just 2 seconds. Mars, it is more. 4 minutes to 20 minutes.
Yes, sir. So that's no. 2 minutes or 2 seconds. Some communication gap is.
For the moon, 2 seconds, madam.
To send the message, or you have to send total thing. What I have, we have to do everything message. So you can see and read the message and according to follow. But surgery means it takes 20 minutes a gap difference in there.
What about it is 20 minutes.
Where is 20 minutes?
Time lag, sir. From the communication, what you send the message to reach Mars and they interpret.
20 minutes.
Your signal to reach there, that 20 minutes. Suppose the light from sun reaches Earth in 8 minutes. No? Like that, our signal going to Mars is 20 minutes.
Okay. So what about robotic surgery is not difficult. It's very difficult because time lag is there, no?
Yes. Another thing is, even suppose in space, even though suppose we are in space station, there is a gravity in space station because the chambers where whatever the OT chamber is there, it will be rotating, and there is an artificial gravity in the theater also. So even, but it's not still no practiced, but there is chances of gravity. You have gravity, you will have some hyperbaric drug can be used in space. We don't know how much extent because we cannot simulate like 9.8 G here in on Earth. We can simulate in space. So we have to, depending on that, we have to calculate the drug hyperbacity. Depending on then only we can give the dose. Maybe it will come in future because till now there is no surgery performed in the theater. Shrikant.
Yes, sir. I was also thinking the same about spinal when they talk. Maybe they have some artificial chambers or there to perform the procedure, but to till date, as said in the Focus article, no procedure has been done, but they're actually planning to go to that level from there also. So thank you so much. I didn't even think this much discussion will happen with this class, but happy to pick up this topic and see you next week. It will be by Gazwaka. I will speak to Jairam and let you know the topic and speaker.
No, thanks for Jekinaboyna initiation starter.
Yeah. Thank you so much.
Thank you, Srikant. Thank you to all.
Thank you, Srikant.
Thank you, sir. Thank you, Shaker.